everyone. Today, Dr. Brown's Medical Educational Webinar Series is proud to present Understanding and Utilizing SYNACTIVE Ergonomics and Role in Successful Feeding Outcomes, Establishing Early Foundation, Part 2 by John Chappel. John is a NIDCAP-trained neonatal physical therapist who has worked with infants and their families for over 37 years. John has a master's in pathokinesiology and is a sought-after speaker, educator, and clinician. In April of this year, John was awarded the inaugural Practice Pioneer Award by the National Association of Neonatal Therapists in recognition of his many clinical accomplishments. He continues to practice through metaphysical therapeutics, providing direct patient care and on-site clinical workshops to neonatal practice professionals around the U.S. Just to let you know that part 1 of this series was recorded on March 26th of this year, and it's located on the Dr. Brown's Medical website, as Steve indicated, at www.drbrownsbaby.com/medical/webinar. Thank you, and welcome, John.
This is Understanding and Utilizing Infant SYNACTIVE Ergonomics. The last time we looked at this, we looked at a different landscape, and that landscape is individual for us as it is for our infants. Today we're going to expand that landscape a little further and try and travel down the road of looking at the pulmonary type of ergonomics we want to facilitate in a nursery. We're defining synactive ergonomics as the scientific discipline devoted to the study, analysis, application of biomedical factors affecting functional synactive acquisitions, an analysis of all the physical properties of the individual infant's body that direct and indirectly affect the work of respiration today. That affects the integration of physiology, movement, and behavior. An understanding of the role of biotensegrity in supportive care to reduce stress, discomfort, and fatigue in the sick infant through efficient energy use in the maternal infant caregiver and ICU environment dynamic. From 23 weeks, the primary focus for all practice professionals who are responsible for guiding the oral feeding skill progression should be to contribute all the aspects of normalizing respiratory functions to support adequate sleep architecture. Infants need to establish consistent sleep-wake cycles to maintain quality awake states during feeding. How many times have we seen people try to feed babies when they're asleep? So this magical time period from 23 to 34 weeks allows us to get in as a developmental team, as a feeding team, and really make sure everyone is attempting to allow the infant to develop the adequate sleep architecture it needs. Now, this is quiet sleep and active sleep. That's why we don't just pin babies down or restrain them or put them in a situation where they can't move. They have to have small micro movements of their entire body to help with the timing of their respiratory functions. The timing of all sucking and feeding behaviors are dependent on the central pattern generator functions of respiration. Central pattern generators are not these magical things. They are hooked up, they are wired, and when they wire together, they fire together. And we're going to look and see how these central pattern generator functions actually get distorted in the extremely small preterm infant. And we're lastly going to look at autonomic controls necessary to establish normal gestation and elimination functions. Respiration is necessary for all oral feeding. Well, I tuned in for that, John. But respiration and feeding are total body synactive functions. And those of you who have heard me do this, it is a 2-hour lecture, it is a 4-hour lecture. Indeed, it can turn into an entire 2.5-day course, as we'll be offering at the URSA Institute for Manual Therapy next year. 2.5-day course on respiration. So together we need to redefine the role of synactive developmental caregiving to include the specific effects of chest wall mechanics in decreasing pulmonary morbidities, allowing for optimal aerodigestive functioning and oral motor control. Our analysis of developmental opportunities must begin at 23 weeks PCA. Only then have we found that place where we can place the infant in the best possible position for optimal aerodigestive and oral motor functioning. I'm sorry about my pointer. It seems to not be working correctly today. So we do this by observing, and contempt for simple observation is a lethal trait in any science. Every single person listening today has the ability to observe and then create conjecture, concepts, and strategies. But how you're observing and what you're observing really is the difference between really good synactive respiratory care for these small infants and care that is by a long shot sometimes very inadequate. So nature's language is a language of relationships. Biological form consists of relationships, not parts. We are going to look at parts today. We are going to do a non-Cartesian type of analysis, looking at parts as a whole. We can't do that unless we, of course, look at, and again, this is Dr. Rawls's developmental synactive tornado, as I call it. Autonomic control is what we are talking about. We're talking about respiration, but you cannot talk about respiration without talking about the motor sensory system that drives it and modifies it. Dr. Rawls says a preterm infant will tell you first what they think of you autonomically and second what they think of you motorically. So we will at the end look at some motor concepts and things that I call respiratory chains that are part of a NIDCAP-based observational system. So when we last left our intrepid hero, that's you guys in the nursery, maybe we should get masks like this for the feeding team. I don't know. We looked at something called respiratory system. I added a word here, 4 synactive functional units. We talked about who were the experts in each one of these fields, and we have to be able to understand all 4 of these components and do it as a team and do it as a compassionate group of people who attempt to make the best possible outcome occur. And we will talk again in depth on each one of these topics. All right, first, we all know retractions. But when I look at retractions, I see retractions as telling me what's happening to the systems and physiological viscera under these areas that we look at. We can tell that by different areas of restrictions and retractions. For example, subcostal and substernal retractions usually result from lower respiratory tract disorders, and suprasternal retractions from upper respiratory disorders. But ladies and gentlemen, we see this all the time. We may see a left lower and a right upper. What does that mean? And in BPD, we constantly see these waxing and waning through all state control, light sleep, deep sleep, watching retractions, but more importantly, watching the areas of movement and non-movement really tell us how this chest wall is developing. Well, we all have come from this area, and we've seen these babies put in this position and posture, and we know that we have to blow up their chests to make them survive. But at some point, this whole system is developing. There's a morphology and an embryogenesis that's changing under our hands every minute. And as you know, I have the utmost respect for neonatologists and neonatal nurses because no one has changed the mortality rates of their patients in as short a time and to as a great extent as they have. But we're talking here mainly about morbidities today, the things that these children carry with them the rest of their lives. And we saw them like this. And I have a patient right now who's 34 years old who was like one of these children, and she is now looking at bilateral lung transplants. I wish I'd known some of the things that I'm going to talk about today because I think we could have forestalled a lot of her problems. So our mistakes, our inabilities, our lack of commitment and focus carries with it a lifelong baggage for these children. So we have to be committed to actually getting this rib cage and everything attached to it, cranium, cervical spine, upper extremities, lower extremity, gut, we're going to talk a little bit about that today, to all be working in synergy to help respiration. All of this is combined. Now, I'm going to ask each person here to decide on the feeding team, are the people in your nursery, is your nursery involved or committed to appropriate synactive positioning to lessening the amount of allostatic load on a rib cage in infant? And you say to me, John, what's the difference between involved and committed? Well, in a ham and egg sandwich, the chicken is involved. but the pig is committed. This has to be a commitment of all parts of the nursery to come together and maybe start thinking in a different way about how we treat our babies with chronic lung disease and bronchopulmonary dysplasia. We've come a long way. We can look at babies, but you can always be observing these areas of the chest. What are they doing today? What is the abdomen doing today? Are they reverberating? Are they working together? Or is something down here creating a problem up here? And we'll talk about that. And each time we look at a baby, is there something we can be doing better? Is there a better way? And there are a number of different ways. You can do this with towels. You can do it with high-level C-flow. You can do it with Dandle. But however you do it, no one system of positioning and no one system of oral motor feeding fixes everything. My old joke at Columbia was when I had students, if you look at this baby, I'm going to go back 3 slides. If you look at this infant, his back is flat, his entire spine is flat, yet his front of his body is domed forward, and really it's deformed. It doesn't look anything like a fetus at 7 months would look, which is a rounded, symmetrical, good-looking chest that has flexibility and drive and motor drive to a degree of respiratory abilities. And that becomes the way we build this chest, and this chest is built under our watch, determines how it's going to look at term. So if you have babies that look flat, have flat backs and that big rounded square belly that comes around, basically you built them wrong. So if their chest is built wrong, how are they going to breathe correctly? Well, when we speak about developing synactive synergies for respiratory function, what do we mean? We have to account for all synactive manifestations that can directly affect respiration. And we do this by observing the individual infant's myriad of overt behavioral cues and the physiological fallout that we produce. We can inhibit negative endogenous events to stabilize and facilitate homeostatic equilibrium. I have to apologize for this slide. This is my fault, but you saw this slide the last time and it came out a little better. It's from Bankalaria's book in 2007. It's page 117. It takes a look at prematurity and some of the problems we have with chronic lung disease. Let's just look at them again. Excess tidal volume, decreased lung compliance. Please keep this in your mind for the rest of the talk. That means that every time we blow a breath into this lung, we create volume trauma. If you have this, you have this. Whoops, sorry. When we look down here, we see that this leads to acute lung injuries, that there is inflammatory problems because of everything else we're doing. There may or may not be vascular injury. There certainly is airway obstruction at times and atelectasis. And this pulmonary edema we're going to look at. Once this edema and inflammatory process begins, how do we facilitate this lung from clearing this fluid and getting its fluid balance back? And indeed, when we look at this, this is now this is a overall statement. I looked at a number of articles through the years on this. It kind of gives you the status quo of where we think we are. Sorry for the pointer, those of you who are distracted like me. When we look at movement and pneumocyte development, type 1 pneumocytes. The pneumocytes are responsible for gas exchange in the alveoli. They are unable to replicate. Once they have been damaged, once they have been irritated, once the body begins to actually break it down because of the fluid pressures. So that's not such a great deal for our kids. Type 2 pneumocytes can proliferate and differentiate into type 2 compensatories and can compensate for type 1 damage. That's a pretty good deal. So we know we damage the type 1s. But we have type 2s that can take the place. But here's the problem. Type 2 only differentiate if there are breathing movements. And let me just say, the more normal the breathing movements, I am sure the better pneumocyte development you have. They begin their embryogenesis around 24 weeks gestational age. Now, all of this is questionable, but it certainly is, through all of the literature I've read, tells us that this is indeed the problem, the potential solution right now. And they are responsible for the production and secretion of surfactant itself. So movement and cellular function, the macro and the micro. We talked about this, we looked at this slide, but I wanted to revisit it. This lung, when it's breathing correctly, not just having air blown into it and recoiling, this lung is developing and changing and growing. It needs to have the support of the rib cage and the diaphragmatic structures that drive it to create the correct axis of movement to allow these lungs, remember their lobes, to fill and slide and inhale and exhale. And they're covered inside and out with membrane. So the external ability for the lung controls some of the internal capabilities of the lung. And serosal membranes and fluids need rhythmic forces to impel or milk edematous regions so the body can facilitate the removal of accumulated fluids. And lung parietal membranes are no different. They line the inside and outside of the organ, and both membranes have distinct physiological roles based on appropriate rhythmic movement forces. This is from Lawyer's article in 1968. And what they did is they did a survey looking at the cross sections of the lymphatic system within infants' lungs who were having hyaline membrane disease and chronic lung, who would go on to die from their chronic lung. And they indeed found that in all of the infants with chronic lung, the entire diameters of all lymphatic vessels were swollen. They were puffy, whatever you want to do. They were edematous. And these infants could not clear that out. And it doesn't happen from pressure volumes from respirators. It happens from gravity, and it happens because the lung has to be moved by the external forces. Now, at 23 weeks, there are very little of those. And the respirator can accommodate until the lung and these lymphatics outgrow it. And at some point, that floppy rib cage becomes a very hard, non-compliant structure. And that's when the lymphatics really have a problem. So a change in early structure and function can be magnified and disrupt consequent developmental events and decrease the individual's repertoire and abilities during the course of their lifetime. And Esther Thelen was someone who wrote a lot of really great articles. This is the battle we fight. This is from Mortola's, or Campbell's book 30 years ago. It basically shows you rib cage and abdomen are the X and Y axis on which normal breath function, functional residual capacity is decided. The total relaxation line towards total lung compliance is decided by these factors, external factors that we control. And the relaxation line is the line of least elastic work, and normal quiet breathing follows it closely. What an amazing statement. Here it is. Deviation from the relaxation line indicates distortion of the chest wall and therefore an increase in the work of breathing. If the rib cage is too loose, the work of breathing goes up. If the rib cage is too tight, the eventual work of breathing that we want that rib cage to morph into is affected as well. And we looked at this, the concepts of inhalation and exhalation from a diaphragmatic function, but we also looked at the rib cage being able to move and the lungs physically moving within the rib cage and the diaphragm pulling this structure down and out and changing in the adult anyway. I don't have any data on this in children, but I don't see any reason why it shouldn't be any different. That at some point there's an ideal inspiratory position of the airway to allow inspiration to come down into the basilar lobes where it's the most effective, and not in the apical lobes where it's the least effective. Again, the rib cage, upper and lower rib cage is almost divided through here, and we'll show this a little more. And lastly, I want the feeding teams to look at, maybe we'll talk about this one day, this mediastinum. Now the heart sits literally right on this diaphragm and is pumped itself. It has an excursion, as does the esophagus. This mediastinum, as Dr. Lauren Rex would say, is the highway for all our fluids. And this ability to have a mediastinum that functions well under many different positions is part of the problems of establishing good feeding control. So persistent global or regional decreases in lymphatic drainage leads to micro and macro stiff spots anywhere they occur in the infant's body, in their biceps, in their foot, in their pelvic floor, in their cerebral spinal fluid system, in their lungs, in their gut. Anywhere there is localized trauma, infection, decreased blood flow, hypoxia, anoxia, irritation and inflammation, or foreign body penetration, this is our intubated infant to a T. It has to be able to move, and fluids are blood, lymph, arteries, veins, nutrition. All of these sites, especially in the respiratory system, have the potential to change electrochemical gradients and sensory motor inputs that create aberrant limbic, hypothalamic, pituitary axis functions, and thereby create maladaptive synactive epigenetic changes. Those of you who heard me talk about this in DINC, we talked about this all day. And we went from the cranium to the pelvic floor in the infant, and then we went on to show how if we don't put the bottom of the baby, the infant's conscious and unconscious somatic sensory systems into effect and have them functioning, the motoric and autonomic system, it basically affects how these babies wind up utilizing their prefrontal cortexes or not. So this kind of posture early on allows a cranium and a neck and a cervical spine to not be pulled in the wrong direction. It allows the upper extremities to form that web of respiration we talked about. It allows the diaphragm, as we showed last time, the angle to be the most efficient for that infant to inspire with. The pelvic floor and lower extremities allow this abdomen to pump and allow it not to overfill, and we'll talk about that. When I talk about respiratory chains, each time a baby arches, each time a baby finger splays or grimaces or yawns or sneezes or extends or sitting on air, all of these things have the potential to interrupt the normal individualized usage of all those motor signals and stress cues. And they sometimes assist the infant and they sometimes don't, and we'll talk a little bit about that. So again, when you look at this infant, what do you imagine these airways to be? Have they changed for the better, these bronchi, or have they changed for the worst? The rib cage certainly is a problem in and of itself. So even when we see a baby grimacing, and a baby, are they holding their breath? Is this motoric signal, stress signal, interrupting as they hold their breath? And then they grunt and they squirm, and then they start to reestablish it, and then they start to become a little tachypnic, and they build up that catch-up concept. Some babies catch up, some babies don't. Some babies need us to protect them from this. Some babies need us to facilitate. All babies need us to facilitate hand to mouth, hand to face, and to stop doing things like this. So again, if you can get your oral motor team to not do this at 20, let's call this baby 28, 29 weeks, you'll have a better feeding outcome. So what we talk about is, I'd like to draw a line right through here. Last week we talked about some of the just superficial problems with the head and neck and cranium changing their shape, and this is an adult rib cage. But there are approximately 120 different articulations that go into a respiratory cycle of inspiration and expiration. If they are not in the right position or the right posture, they will not be effective. That is called kinesiology. So what we see is, and this is an adult, but definitely in infants, we see that the head, neck, and shoulders really have a lot of impact into the upper half of the rib cage. And the diaphragm and lower extremities seem to have a lot of impact in the lower part of the rib cage. So we actually wind up having babies and make them a little schizophrenic breathers in a lot of ways. So what does this mean? Well, what it does is, remember the fourth functional unit, the neural controller? Well, here what we have is, you've got your pneumotaxic center, and I can't ever pronounce this word, apnoistic center. These are the areas that are responsible for what? We know this, basic physiology 101, Herring-Brewer reflexes. It's designed to protect that baby against overinflating their lung. But guess what? That's what we've been doing. That's what we have to do to keep them alive. So they wind up having a neurological bias to overinflation, And then when we ask them with that tight rib cage, remember, this is all tightening into inspiration, this is tightening as well into inspiration. And then when we ask them to expire, the rib cage is completely locked. And all of this input from the motor neurons controlling the respiratory muscles into the respiratory rhythmicity centers are all malfunctioning and creating an area where even stretch receptors of the lungs can't develop a good feedback system between these three things. And what do? You get apnea. What do? You get bradycardia, because your chemoreceptors and baroreceptors have been changed. So paying attention to this part of the body gives you better signaling processes into here, and definitely into the higher centers, the cerebral cortex, the limbic system, and the hypothalamus. So motor development is a product not just of patterns of muscle firings alone, but a complex interplay of individual active and passive components established by the exacting parameters for positioning and movement. We determine our infants, we determine how they do. Many of you know, no matter what has happened to the baby, what is going on with the baby, you never blame the baby. If you have the courage, go into the bathroom and look in the mirror and see, is any of this your problem or fault? It's all your problem. But we have to be more judicious at saying to ourselves, please, let's do a better job of this earlier on. And the basic take-home message is, I'll just stop here for a second. If you're a medical and a nursing team, you have people whose entire career is based around the concepts, perils, pitfalls, normality of developing a better feeding outcome. If you call these people in at 34 weeks, those people have missed golden opportunities for other people to help you modify and seize the correct opportunities to make better feeding an earlier and more dynamic process. And that's why we're doing these lectures. I would have given anything for a Dr. Brown's system in 1977, wouldn't we all? The effects of gravity, tissue elasticity, joint architecture, freedom of general movements, visceral organ positions, and synergistic synactive motor sensory patterns form contextual demands and the pathway for synactive neuromuscular systems. Now here's another thing. I'm just going to stop right here. What we have when you're on a feeding team, and feeding teams are told that what they do doesn't matter. At the end of this lecture today, you'll see that everything you do matters. And when you become conversant and you do your studying, and I admire you all for taking just these 2 hours out of your busy lives to try and find a better avenue, an aha moment that allows you to bring this material back. We need to not create in isolation. We need to get together. We need to come together in conferences. We need to come together within our hospitals and find that other person who heard this lecture and say, what was that all about? And sit down and go over these slides. And maybe a year from today, you make this presentation to your medical staff or your nursing staff, and you get together as a developmental team. I'm giving you pieces of information you take with your amazing knowledge and you put it together, probably better than I will. So when you correctly position an infant so their synactive needs are being fully met and sustained, you're allowing for the proper building of sleep architecture. Is there anything more important for a feeding therapist to help put together after respiration than sleep architecture? What does this mean? Turn down the lights. You know Marianne, that really loud person who talks about her dates right over the babies? Identify her as an agent of stress. Tell her, look, or the medical team that pays no attention to babies and rounds with loud people talking. I would say to those people, if you're on call tonight, you don't mind if we come in at 3 in the morning and round around your bed, because obviously it's not affecting this baby's sleep, so why should it affect yours? It's time, as Marie Coughlin says, is to kind of stop the madness and really come together and decide we're all in this together, and it's all for the infant. So we need to identify our agents of stress. Is it cyclical lighting? Is it whatever you pick? So You know, is it music therapy or the lack of it that's creating a better or worse environment? The infant's predominant state on which all of the synactive tasks are based. Thus, sleep states exert major effects on moment-to-moment expressions of breathing, whoa, and autonomic control, as well as evoke responses to specific challenges. Sleep and breathing are linked at the deepest human levels possible. There is deep sleep, there is active sleep, there's delta sleep, there's alpha sleep. All of these things, these babies have to be able to put together before they can assemble that awake state that is the magical time for them, that they have to then feed with you and their mothers and their fathers and their brothers and sisters and everyone. If we're not working on sleep and we're not working on breathing from the 23rd to the 34th week, really, we're asking for the feeding problems we get, or I should say our babies get. So the momentary changes are typically far out of proportion to demands dictated by metabolic needs. This is a portion of variation associated with the state, reflects neural processes and other than mechanisms essential for homeostasis, and in some instances may compromise vital needs. So you change the body, you change the brain, you change the body, and you change the physiology. Florence Nightingale said, always place your patient in a position where they can succeed. We create changes in the infant somatic synactive synergies at the macro level to induce embryological opportunities for healing. Remember this, healing and development to occur at the cellular level. When optimal position and handling occur and change anything, I put my hands on this baby, their respiratory rate went down by 10. Their color changed from white to pink. They took a couple of nice sighs and they went into from a fuss into a deep sleep. The only reason that works is because you're doing it on a cellular level. You're changing PO2, CO2, you're changing those pneumotatic centers. Everything is changing on a cellular level. It's not just something you do to make babies feel good. So when we look at why we control respiration, well, if we can make work of respiration less, the amount of respiration in minutes will go down. That's how lungs work. So I picked an arbitrary between 16 hours of the sleep that a baby gets and a wake time, for argument's sake, let's say 40 breaths per minute. In 1 hour, that's 2,400 breaths. In 24 hours, it's over 5,700 breaths. Let's stop for a minute. If you decrease that 40 breaths a minute to 36 a minute, you have 200 less breaths an hour, and you have 4,200 less breaths a day. Do you know any infant anywhere that shouldn't be getting this as part of their developmental care at any week? So why should an infant in any nursery at any time, day or night, have to increase their allostatic load because they're not positioned correctly and they're not feeding into their respiratory system? We're going to change a gear here and take a look at something else. Fluid is the true lattice that an infant's body is built and functions upon. Here we see an infant. We see a chest that's domed. Even though the baby's positioned well, we have to do this with this infant, but we start to see an abdomen that's also kind of puffy. It's not draining correctly. It's not draining correctly because part of the ability for the abdomen to drain is based on how the respiratory system works. This is just look at this. We talked last week about what the diaphragm, all of this material hangs from the diaphragm. A liver, which is 20% of the baby's mass, is here. The cranium up above is 20% of the mass. If you have them going in two different directions, you've created a torsion in here that this abdomen can't pump against. We have peritoneal and retroperitoneal spaces, and it hangs, and it's all down here into the pelvic floor, and this has to pump. Those of you who've been, we can do a half an hour on the influences of the pelvic floor and lower extremities on the diaphragm and abdomen, and maybe we'll do that next time. But this is what, there are watershed regions in the peritoneal cavity. There are areas of fluid stasis. I just want you to look at these stars. The fluid generated centrally comes down into the pelvic floor and is pumped laterally along the sides of the body. How does it do this? Well, it does it by electrochemical charges, but movement has to be here, so there are no areas of edema, tightness, or stiff spots, because the movement actually creates some of the electrochemical gradients, as well as the pull of gravity and the pull of the diaphragm and the respiratory system above. And we tend to get a pooling down here of fluids and in everyone, especially adults, when we're up against gravity. Now, the next picture is a surgical picture. If you don't like to look at people's insides, don't look at this, but these are adhesions. And there are adhesion sites in adults and adhesion sites in preterm infants that we know occur where these places don't pump. The base of the liver, the central cord that you saw. All of these things. And especially once a baby has had a surgery through here, it's even more paramount that we have the respiratory system working well and the pelvis flexible enough so that these systems can move with each breath. And 90% of the peritoneal fluid is cleared at the subphrenic space by the submesothelial lymphatics. This small area here, this potential space, it is a space filled with fluid. These lymphatics are connected with the lymphatics at the other side of the diaphragm. This is looking superiorly at mid-liver and up. So during inhalation, the respiratory movement in the diaphragm causes the entire peritoneal sac to shift caudally, and the subdiaphragmatic parts shift medially from their lateral neutral positions. The abdominal wall is pushed forward during inhalation and returns with exhalation. The motility of a normal peritoneum is to rotate. How many of you have heard that before? The right rotates right and the left rotates left. What happens in the middle? Well, it gets squeezed out is what happens, like a sponge. So mobility and motility of the gut are different. The net result is neutral if the gutters are clean and the drainage fields are clear. And this is, I have to thank Mr. Lino Cedros for all of these slides. He is my mentor and friend and the director of URSA Educational Institute for Manual Therapy, and he is a joy to be around. And he is just has a wealth of knowledge that I've only experienced in one or two other people in 40 years. So when we talk about fluid, and this is new to you, Dr. Fred Mitchell, who was a famous DO, said, everyone is down on what they ain't up on. And you'll come to someone and say, well, I think it's the gut that's, and they'll say, that's impossible. Why? Because they ain't up on it. So it's up to you to get them up to speed with this information. So lastly, we're coming to the close. Thank you, God, right, for everybody. Okay. I wanted to show you a NICAP primer that I've come up with. It's just something. It has nothing to do with NICAP. This should be, you know, it does have a lot to do with NICAP, but it's not endorsed by them. It's just a different way to think about things. These are what I call the yardstick and no-brainers. There's two of them. If you're dealing with respiration, you're looking at respiratory rate, O2, PO2, color, heart rate, all of those things. That you've been taught. But each time a baby does a motoric movement, it is either putting them together respiratory-wise, it is either interrupting it so that they can establish a new base of control, or it is degrading it. And this is what I call respiratory chains. And here's what we observe. Remember, observation, a lack of simple observation is a lethal trait in any science. You all see these. So each time a baby has tremor or twitching extremities or that diffuse squirming, is it something that's helped them put themselves together? Are they better? Are they resting easier? Or is it something that degrades them and increases their allostatic load, and now their respiration rate is higher, their PO2s are lower? Arching, never a good deal, but it is a normal function. Trunk tucking, stretch drowning, where that baby, as Marianne describes her date over this baby's isolette, this baby is shaking and stretch drowning, their legs come up, they're sitting, doing a sit-up. All of these interrupting the neural control of this infant and whether or not they can put themselves together. It behooves us to diminish these as much as possible through whatever means necessary, and they will come back to allow a lesser allostatic load on the infant and a better feeder. We've talked about upper extremities as being the web of respiration, and the upper extremities are replete and filled with all types of movements that show us that the baby is maybe being a little stressed by gas in their belly, or Marianne's description of her date the night before, or somebody slamming a door, or rounds going around too long for their bedside. And then they begin to try and pull themselves together with other things like hands clasping, hands on face, hands to mouth, foot clasp, leg brace. These are all really nice signs, and actually as a physical therapist, These are all what we call closed kinetic chains, where all human beings bring themselves back together, and especially infants, into a better homeostatic and kinesiological control. So lastly, these are the no-brainers. We all know these, but each time a baby does this, they interrupt their neural control and their somatic system and visceral system. These are respiratory overload signs. They're respiratory visceral. You sort of can't have one without the other. If you're dragging in respiration, you're dragging in viscera. If you're dragging in viscera under the NIDCAP world, you're dragging in respiration. Sounds and sighs may be good. Hiccups are normal, but are these hiccups occurring every time you overfill that belly? And the people in your nursery are working on volume and not readiness to feed. And we'll talk about it in the last slide. You know, these are things you have to bring to them. Okay. Burping, grunting, gagging, vomiting. And I'll just mention too, crying is never a good deal for an infant. The more a baby cries, the more you upset the neural control in that infant's milieu in life. Crying is not a normal activity for the respiratory system. It degrades it on every single one of the 4 levels that we talked about synactively. So about 80% of a baby's communication is through its body's movements. Infants can't wait. Catherine Barnard, who just passed away, if any of you have ever had any classes with her, was just amazing. And these infants can't wait. It has to happen now, people. And I think it has to happen yesterday, frankly. So you have this ability to look at the infant's body movement. This is what you bring to the table as a feeding therapist. You bring this to the table. You're the person that has the courage. Don't create an isolation. Try and find other people who think like you. Go to conferences. Contact the people you're supposed to contact. Get the help that you need. And this baby's like, yeah, you're going to feed me, pal? Do you have any idea what I've been through? You don't know. So here are what I consider some of my feeding mavens. These are our godmothers of infant feeding. They're the people who have developed amazing systems. And there are many more people who I've talked with at lectures who are feeding experts. But all of these people I've talked with recently, and they all have very current systems for feeding. Find any one of them, hook up with them. They will have the answers for a lot of your questions. They may not see the things that I talked about today as being relevant, but they'll see a lot of other things as being relevant. I think all these people will. So all of these people have their own systems, their own strengths. No one feeding system or evaluation techniques fixes pretty much everything. So that's why you got to stay on your toes. So you know, if you're new, find these people, find any of the people who talked at NANT, find any of the people who used to talk at developmental interventions in neonatal care. You can go on the NIDCAP Federation International website. They will help you find people that you can hook up with from godmothers and godfathers. We originally started, and this list was like 20 people long, so we're just going to do this. So I think, thank you very much for this. I'm sorry for the delay. We got through what we wanted to get through, and I will take questions. I know I'm a lot younger than I look. So thank you very much, everyone, and go out there and give them hell. Bye.
Thank you, John, for this very informative presentation. We really appreciate it. Unfortunately, we are out of time for questions. We will definitely forward any questions that were written in the presentation to John. We'll get his answers and we'll post these on the website along with the presentation and the copy of his slides. So be sure to check our website, www.drbrownsbaby.com/medical/webinar. Thanks again, and this concludes today's webinar.